involved with RSN for nearly 15 years. Support from someone who's been there makes all the difference.
Hey David, what are you listening to?
Kidney Talk, an online radio podcast that talks about kidney disease and the prevention of it.
Oh, cool. Where can I find that?
Oh, you can download it on iHeartRadio, Google Play, and Apple Podcasts.
Oh, nice. I'll definitely have to download that.
Shout out to Renal Support Network, the annual Renal Support Network essay contest. I won the Renal Support Network contest last year, the Warrior, and we are all warriors. So thank you. Keep on doing all that you do, and be happy and healthy and keep the hope. Thank you, Renal Support Network. Woohoo!
As a kidney transplant recipient, I find that having an actual publication like Kidney Talk is an invaluable resource for any kidney warrior at any stage.
RSN keeps me informed of kidney advocacy issues so my voice can be heard.
I'm really looking forward to the prom this year and meeting people who are just like me. Dressing up is super fun and all the activities are amazing. Can't wait to see you there.
Hi, I've been participating in the Renal Support Network 30-minute fitness Zoom classes. Not only have I lost 15 pounds, but I can also strike a yoga pose like this.
When I created Renal Support Network back in 1993, I had no idea the impact that I would have among my peers. An illness is too demanding when you don't have hope, and peer support, education, and knowledge are crucial to our survival. We have a great week planned with some incredible speakers, great information for you to share, learn, so we can survive and thrive with this illness. It's imperative. So stay tuned. We're going to have a great event, and a shout out to our corporate mission partners for making this happen. Well, welcome everybody. It's my pleasure to introduce our MC for the day. Her name is Wendy Rogers. She was the star of our video. She opened it up for us, and she's an incredible advocate nationwide, and a lupus survivor, a kidney transplant survivor, and just a great friend. So it's my pleasure to introduce Wendy Rogers.
Thank you so much, Lori, and welcome everyone to Hope Week. And I hope that each one of you leaves with even more hope. So our next speaker is going to bring such interesting information. And the question I'd like to ask you guys, are you a stoner? So we have Dr. Kernhand. He's a clinically active nephrologist, professor of medicine at Harvard Medical School, and professor of epidemiology at the Harvard Chan School of Public Health. So he brings two great perspectives to us. He received his MD from Harvard Medical School and his, I guess this is Doctor of Science, from the public health school at Harvard as well. And he has some interesting focuses. Some of them I can't say. I'm really curious about the nephrolithiasis. I want to know what that is. I haven't recognized that word before. But he also focuses on some other common ailments such as CKD, hypertension, gout, and hearing loss. So let's welcome Dr. Gary C. Curhan. Thank you so much for being here.
Thank you very much. And thank you to Lori for inviting me. Lori and I have known each other for longer than either one of us will admit, but it's been really a pleasure to be joining you at the RSN week. A few disclaimers here. I can't sing. I can't play the guitar. And my kids say I don't tell good jokes. So, and the last thing is kidney stones are not funny, okay? So it was a tough one to follow Carla. I'm certainly glad that she went first, but this session's gonna be a little bit different, okay? So I'm gonna talk for about 30 minutes. I do love talking about kidney stones, but I will limit my remarks to about 30 minutes. And then there'll be plenty of time to ask questions at the end. So I'm gonna share my screen. Okay, Wendy, do you want to give me a thumbs up if you can see my screen? Okay, great, okay. All right, so this was the talk that I was asked to speak on, is about understanding kidney stones and most importantly what you can do to prevent them. As Wendy nicely introduced me, I am a nephrologist. I actually only see patients with kidney stones. And actually, kidney stones, the medical term is nephrolithiasis. So that's why I put that in there, but most of them refer to it as stones. And I'm gonna talk about some facts, some myths, and we'll talk about some tips. This is not a lecture by any means. One of my kids actually helped with the slide and said, Dad, we need a little more color. Let's not make it so boring. So these are the kidneys and these are stones. So one of the things that I get asked all the time is, what is a kidney stone? And I remember when I was just starting out and would bring some stones home and show my kids, they couldn't believe that they actually are stones, and they are, they're concretions. They actually grow in the kidney. I assume many, if not all of you, have seen some pictures of the kidney. This is a slice of the kidney, and this is the top part where all the filtering goes on, the glomeruli. And then there's these things here called the pyramids. And usually it's right at the tip of the pyramids where these stones form, and they grow of all different sizes. But if they're just sitting in the kidney, they almost never cause any problems. But when they break off and they drop off from the kidney down into the ureter, that's the tube that connects the kidney to the bladder, that's when they come to your attention. As you may have heard, if you know of anybody that's had a stone, or if you've had one yourself, say it's the most severe pain anybody can have. For a woman that's gone through natural childbirth and has had a kidney stone, most of them would pick natural childbirth any day of the week. So extremely painful. They form when the urine just gets too concentrated. People sometimes have a misconception about what urine is. Urine is just water with a bunch of the waste products dissolved in it. You know, as you know, the blood goes to the kidney filters it, it reabsorbs some things, it secretes some things. But the water, urine is just water with the waste products dissolved. And as long, again, as they stay dissolved, it's a liquid, you urinate it out, no problem. But when it gets too concentrated, then crystallization occurs, or precipitation, and those crystals eventually grow into a stone, and that's what causes the problems. Again, they're oftentimes so painful because when they block the ureter, the pressure builds back up into the kidneys. If it's just transient, it doesn't damage the kidneys, but if it blocks the ureter for weeks to months, then it can cause permanent damage to the kidney. And the stones, nephrolithiasis, I'm talking about stones that form up in the kidney. They can form in other places. They're actually called bladder stones, but we're just going to be focusing on kidney stones. So again, they may form in the kidney, pass down the ureter, and hopefully make it all the way down to the bladder. And then eventually it's easier to pass it out because the urethra, that's the tube that connects the bladder to the outside, is bigger than the ureter, which is much smaller. Okay, so now you know about kidney stones. We've talked about different places where it can pass, and sometimes they pass on their own. Actually, it really depends on the size and where they get stuck. There's all different places where the stones can get stuck. A common place is right as the ureter goes into the bladder because of the way the angle is, and it's a little bit of a narrow there, so that's a common place. But eventually most pass. If not, then sometimes we need our urology friends to put a tube up, and that usually goes up through the urethra into the bladder, and then goes up, and we'll oftentimes use a laser to disintegrate the stone, or a basket to grab it and move it out. Okay, so I didn't mean to scare you, but anybody can really get a stone. It's much more common in men than women. Over the lifetime, close to 20% of men, so 1 in 5 men will form a stone, and now it's close to 1 in 10 women will get a stone. And again, while they're more common in men, kidney stones can affect anyone. And even if you don't know anybody personally, you probably know some of these other people, Anna Kendrick, Billy Joel, or Reynolds. Not many people talk about it all the time, but once you hear that somebody you know has had a kidney stone, then the stories start to flow. And there's many others, political people, presidents, Benjamin Franklin, religious leaders, John McCain. So all sorts of people have had kidney stones, again, extremely common. So now I'm going to show you some of the nastiest looking stones you probably have ever seen. And they come in all shapes and sizes. These stones these had to be removed because they were so big, and these are what we call Staghorn calculi. And if you've seen the anatomy of the kidney, these grow in that collecting space and they fill up all the inside, the drainage part of the kidney. So we call them Staghorn because of the way that they look. But I've showed this here also because many people say, well, I know what my stone was made out of because of its color or its shape. And unfortunately, you can't tell what a stone's made out of just by looking at it. You really need to retrieve it. And that's my nice way of saying, please stick your hand in the toilet and grab a stone if you do pass it so that we can send it off for analysis. There are different types of stones, and the different types of stones have different reasons why they form. And so the evaluation is similar, but the treatments are actually quite different. But unfortunately, oftentimes we can't retrieve a stone. It's passed in a location, or it was passed without being aware that it passed. So sometimes we just have to guess. And if we're going to guess in first-time stone formers, over 3/4 are calcium-based stones, either calcium oxalate or calcium phosphate. But overall, the most common one is calcium oxalate, about 75%. Calcium phosphate is the next most common. And then there's uric acid, struvite, cysteine. These are make up a small percentage of first-time stone formers, but you'll see types of stones like cysteine, it's 1% in first time, but then it goes up to 3% in recurrent, and that's because cysteine stones are much more likely to recur. Calcium phosphate, again, goes from 14 to 18%. So depending on the type of stone, they're more or less likely to recur. But still, overall, calcium oxalate is the most common. So sometimes people tell me they had a calcium stone, and I just emphasize that it's not pure calcium, it's calcium something. So how common is stone disease? Well, the US does national surveys of individuals' health, and they sample people. And from the sample, we can extrapolate to the whole US population. So one of the sampling periods was in the late 70s. And at that time, just over 3% of the US population had ever had a stone. And just about 30 years later, now it's almost 3 times higher, the number of people that have stones. And the most recent estimate is that there's over 19 million US adults who have had at least one kidney stone. So this is extremely common, much more common than certainly almost all the other kidney diseases that we talk about. So when we talk about stones, people want to know, well, how likely is it I'm going to get a stone? Because I do a lot of work on diet and stone disease, and I'll show you some of the results in a little bit, but people always wonder, well, should I eat this or should I not eat that because I don't want to get a kidney stone? And I always ask, well, have you ever had a kidney stone? And if they say no, then I tell them, I don't really care what you're eating. If you've had a stone, then I certainly want to prevent a second one, but I don't want people to worry about preventing their first stone. But then they say, well, how likely is it for me to get a stone? And I'm involved with some very large cohorts that have been going on for decades. This one's a study of 50,000 men. This is the Nurses' Health Study. Some of you may have heard it. That's been going on for 4 decades. It's over 120,000 women, and this is another Nurses' Health Study. This has 110,000 women. And we've been following them over time and identifying new stone events. And from that, we can then estimate how likely it is someone who's never had a stone before will get their first stone. So let's first look at men. That's in the yellow dots here. And you'll see that in a 45-year-old man, the risk of forming their first stone is about 4 per 1,000 per year. So even though I told you that stones are really common, the likelihood of getting your first stone is, if you had 1,000 men, only 4 of them would get a stone in a single year. And it goes down with age, but it doesn't go to 0. And even people in their 70s and 80s can form their first kidney stone. If we want to look now at younger women, say 35-year-old woman, it's about 2.5 per 1,000 per year. Again, goes down a little bit with age, but it isn't until much older that the rates in men and women are equal. So I tell people not to worry if you've never had a stone before. But clinically, what we're trying to do is prevent recurrence. So people say, well, once I've had a stone, how likely am I going to get another stone? And they never like to see this number. So it's about 5% per year after you've had your first stone, the likelihood of getting another stone. Now this percentage is influenced by a number of different factors, and that's why we do evaluations, because we're trying to see how likely it is for an individual, not just a population, but for an individual to form another stone. So what are the things that are related to stone formation? Well, it really depends on the type of stone. Remember I mentioned before there's different types. There's some genetic ones. You may have heard about calcium oxalate stones that may be due to primary hyperoxaluria. That's a condition where the liver overproduces oxalate, and so there's calcium oxalate stones formed, but there's also calcium oxalate depositing throughout the body, ends up damaging the kidneys and other organs. And so that one has different approaches. There's some other genetic disorders, something called cystinuria, where they form cystine stones. But the vast majority of stones do not appear to be genetic causes, as best we can tell at this point. And the fact that I showed you before that the number of people in the United States with stone disease has almost tripled in 40 years. We don't see that with genetic disease. That's certainly environmental. So we want to understand what are the environmental factors that we can modify to reduce the likelihood of forming another stone. So here's a partial list of risk factors for stones. On the left, you'll see age, and I showed you those graphs before, how it varies with age. I told you that women are less likely to form stone than men. There's geographic variability. People in the southeastern US are more likely to form stones than in the northeast. If you have a family history of stones, you're more likely to have a stone. I'd mentioned some genetics, but for common stone disease, we don't know what the genetics are yet. Diet, I'm going to spend a lot of time on. That's what I do a lot of my research on, but it also seems to be playing a quite important role. And then also what we measure in the urine, and I'll talk about that as well. But sometimes people think about kidney stones as just being a problem with the kidney, but in fact, there's a number of systemic conditions that dramatically increase the risk of stone disease. So there's something called inflammatory bowel disease and Crohn's disease. It's inflammation usually of the small intestine. Those individuals are more likely to form kidney stones. People with primary hyperparathyroidism, this isn't secondary or tertiary that we may see in people with chronic kidney disease or on dialysis, but primary hyperparathyroidism. Turns out that obesity is associated with a higher risk. People with gout are at higher risk, hypertension, diabetes, people who've had gallstones. So there's really a lot of different reasons. Some of these are modifiable and some aren't. But I tend to clinically focus on the modifiable risk factors. So how do we prevent kidney stones? And I want to start with diet, because diet appears to play a very important role. So I'm first going to talk about different nutrients in the diet that may be associated with risk. And on the left side are those nutrients that may be associated with higher risk. So one is oxalate. And remember, right now I'm talking about calcium oxalate stones. Okay, again, the most common type. So if you eat more oxalate in the diet, then more oxalate gets absorbed, more oxalate comes out in the urine. You're more likely to form a calcium oxalate stone. Turns out higher sugar intake, whether it's sucrose or fructose, also is associated with a higher risk of stone formation. If you eat more salt, it's not just bad for your blood pressure and for your kidneys, but it also increases your risk of kidney stones. Turns out if you eat more salt or sodium, that leads to more calcium coming out in the urine, and that increases the risk of kidney stones. It also can increase bone loss. So again, there's lots of reasons to reduce sodium intake. People that take very high dose vitamin C supplements appear to be at higher risk. Calcium supplements appear to put people at higher risk. And I'll talk about that in just a minute. And again, it's not just sugar, but sugar sweetened sodas and juices put people at higher risk. Now, if we look at the right side, we'll see factors associated with lower risk. And the first one is dietary calcium. When I started studying kidney stones, it's been several decades now, people were told to restrict their calcium, but nobody had ever done a big study to look at that. And it turns out when we looked at it in our 3 cohorts, those 2 female and 1 male cohort I showed you before that involved hundreds of thousands of individuals, we found that actually a higher calcium intake from the diet was associated with a lower risk of kidney stones. Another nutrient that's associated with low risk are potassium-rich foods, magnesium-rich foods. Caffeine is associated with a lower risk, and phytate. But these are just general factors. And then when we looked, some of these risk factors vary by age, sex, and body mass index. So it is complicated, but we're learning more and more to be able to tailor our recommendations to individuals to help them reduce their risk. So I do want to just take one slide to talk about calcium. Again, the vast majority of stones are calcium oxalate, and so it kind of made sense that if you were eating a lot of calcium that you should try to avoid it because it will reduce the amount of calcium coming out in the urine. But it turns out that's not a good idea. In all three of our cohorts with increasing calcium intake, the likelihood of being a stone former goes down. And so you may ask, why is that? Well, it turns out just like calcium and oxalate stick together in the urine to form calcium oxalate stones, they also stick together in the gut. So if you eat calcium-rich foods, at the same time you're eating oxalate-containing foods, they will actually bind together. They'll form calcium oxalate crystals, just like they do in the urine, but they're in the GI tract. The GI tract's big, and they just pass unchanged in the stool. So by eating calcium with the oxalate-containing foods, you lower the amount of oxalate in the urine, and it reduces the risk of stone formation. So people always say, well, what is oxalate? Well, if you've never had a kidney stone, don't worry about it, okay? And many of these foods that I'm showing here are actually healthy foods. If you haven't had a kidney stone, I really want to make that clear. And if you have had a kidney stone that isn't a calcium oxalate stone, then this doesn't matter either. So this is really only for the most common type of stone. But the food that contains the most amount of oxalate that we know of is spinach. So I do encourage my patients that have calcium oxalate stones to avoid spinach. But there's a number of other foods that also are very high in oxalate. And I should say that most of the foods that you eat have probably 0 to 5 milligrams of oxalate per serving. So you can see that spinach is orders of magnitude higher. Sometimes people say don't eat nuts, but actually it turns out almonds are high, but peanuts aren't as high, and pistachios are even lower. So I do spend a lot of time trying to dispel myths or misunderstandings that individuals may have about different foods. And I also put potatoes here, and that's because potatoes are a starchy food. They really don't have a whole lot of nutritional benefit, and they are high in oxalate. So it's another reason to avoid potatoes. So you remember before that I mentioned that urine is just water with a bunch of stuff dissolved in it. And as you've probably heard when you're talking to your doctor about fluid and urine output, that the main determinant of urine output is how much you drink. And so when we looked at our cohorts and we asked them about how often they drank 20 different beverages, the people that drank more fluid each day had a lower risk of forming a kidney stone. And that we already knew that, but no one had actually shown it. So you can see in all three cohorts, this is with increasing fluid intake, the lower the risk. But not all beverages are the same. Okay, and when I advise individuals to drink more, they often will say, well, what can I drink? And so we actually did a study in these three cohorts where we looked at different beverages and we taking into account how much fluid they were drinking, because we know that the fluid's beneficial, but we want to know, is there something more about the beverages that may alter the risk, either increase it or decrease it? And so it turns out that coffee, tea, beer, wine, and orange juice are all associated with a lower risk of stone formation beyond just the reason for fluid intake. So you may ask why. So coffee and tea, and I should say that it's caffeinated and decaffeinated coffee that are associated with lower risk. So it may not just be the caffeine, there may be something else in coffee that's protective. And then beer and wine, we know that alcohol interferes with the ability to concentrate the urine. So that may be why that alcoholic beverages decrease risk. I do want to point out here that I do not prescribe beer or wine to prevent kidney stones, okay? But as all of us know, when we've been in certain situations and we've been advised not to do this, not to do that, at least for moderate intake for kidney stones, it is not harmful and potentially is protective to have moderate alcohol intake. Orange juice, you may think, well, I had said earlier that we don't want sugar-sweetened beverages. And even if it's naturally sweetened, orange juice, it does contain a lot of calories, a lot of sugar, but there's also something else in the citrus juices, and particularly orange juice, called citrate. And citrate, it gets into the urine and it inhibits stone formation. But again, I don't prescribe orange juice just because of the additional calories and sugar that's involved. So as far as higher risk, I had mentioned these before, the sugar-sweetened beverages, whether it's soda or punch, are associated with a higher risk. So when we're advising, and again, of course, water is the safest, cheapest, and most effective beverage. I don't want to forget water. Just water was our standard here, so these were all compared to water. but water is really what we recommend, and adequate fluid intake is critical to preventing stones. So I've told you about some different nutrients, but there's also, you may have heard, we talk about dietary patterns. You may have heard about like the Mediterranean diet or the DASH diet. The DASH diet was developed to try to reduce the risk of hypertension. It's the dietary approaches to stop hypertension diet. But we've applied the DASH diet to looking at a number of outcomes, and one of them was kidney stones. And it turns out in all three of our cohorts, the more DASH-like your diet was, the lower your risk of stone disease. Now, this hasn't been studied in a randomized trial. These were just observational studies, but we know that even if it doesn't reduce the risk of kidney stones, it certainly does reduce blood pressure. So we often advise people to follow a DASH-like diet. So I was talking about diet. So there's some other non-dietary approaches too. So it turns out that in individuals' weight, independent of their dietary intake, is associated with a higher risk of kidney stones. And these are, again, from our three cohorts. And actually in women, it's almost a straight line that the higher the weight, the higher the risk of kidney stones. In men, it goes up. It seems to flatten out a lot. But again, while it's not easy to lose weight, it appears that if individuals are able to lose weight, that will reduce the risk of stones. And at a minimum, we focus on weight maintenance. Okay, so we've talked about the dietary and non-dietary factors. Now I want to talk about urine. You know, nephrologists love to talk about urine. And for kidney stones, it's really the cornerstone of the evaluation. So we actually ask patients to perform 24-hour urine collections. For those of you with, that have had kidney disease, you probably have been asked to do this, but usually you were asked to do it to measure protein, maybe some other factors. But for kidney stones, there's a whole big panel of factors that we measure in the urine that help us guide our recommendations for preventing new stone formation. So not surprisingly, for calcium oxalate stone formers, if you have more calcium in the urine or more oxalate, that'll increase the risk. And if you have more citrate, remember citrate I mentioned before is an inhibitor or blocks stone formation, and also volume. So again, the more you drink, the more you urinate, the lower the risk. Sometimes people use these terms like hypercalciuria or hyperoxaluria as if there's a certain threshold beyond which the calcium is too high in the urine or the oxalate. And it turns out the risk is really continuous. It's almost like blood pressure and blood sugar, all these things that while we may have some arbitrary cut points for defining whether someone has abnormal or normal, I really don't use those terms because the more calcium or oxalate in the urine, the higher the risk. So I often use an analogy of like a cup of coffee. So if you have a standard cup of coffee, you might be able to put 2, maybe 3 scoops of sugar in there. You stir it up, it dissolves. But if you keep putting sugar in there, eventually you're going to exceed the ability to dissolve all the sugar. And so again, that's the way that I think about how do we keep calcium and oxalate dissolved? Well, one is if we can increase the urine volume by drinking more, that will reduce the concentration or the likelihood of crystallization of calcium and oxalate. Or if we can increase the citrate, and oftentimes we use supplemental citrate. There are citrate pills that we can use that can raise the urine citrate. So there's lots of different approaches that we use to either reduce the calcium or oxalate in the urine or increase the citrate or volume. So let me just show you some data about 24-hour urine calcium. And this is from, again, our cohorts where we ask participants, and these participants are really amazing because they do all this for free and they've been doing it for decades, but we've learned a huge amount about kidney stones and other conditions. So this is from about over 3,000 for our participants, those with and without kidney stones. And with increasing urine calcium, that's down this slide, as you go up, the risk of stone formation goes up. And there really is no threshold. These are like the standard cut points, but you can see even, quote, the normal range that the risk is much higher than just 1. That's the comparison point. So this idea of normal really doesn't work, and the risk seems to go up continuously. So we do whatever we can, sometimes with reducing sodium intake, sometimes with medication to reduce urine calcium. But another important piece is the volume. And some people think that they drink a lot. And again, if you don't form kidney stones, I'm not really interested in how much you're drinking or peeing. But if you have formed kidney stones, I'm very interested in. And so I'm just showing you some information here from 3 of our cohorts. And it turns out, not surprisingly, that the people who've never had a stone have higher urine volumes than those who haven't had stones. But the urine volume between men and women are actually quite similar, which sometimes people don't appreciate. So I just want to show you what stones look like and when they get diagnosed. And this is a CAT scan. And when we look at CAT scans, just to orient you, pretend that the individual is lying down on a table, you're at their end where their feet is, they're lying on their back, and you're looking up through their feet and towards their head. And that's what this is. This is a cross section. This is actually their spine, okay? And here, these are the kidneys. There are two kidneys on either side. This is the aorta, the vena cava. Most of this under here is intestine. But you can see what these red arrows are pointing to. What's that white stuff? It's almost the same color as bone, as you can see. Well, actually, those are both calcium oxalate kidney stones. These are sitting in the kidney, so these aren't causing any problems, okay? But I'm going to show you another CAT scan, and this is a different slice, so this may be a little more recognizable, as if you're facing the person. This is the right side, and this is the left side. This is the aorta here, and these are their kidneys, okay? I'm sorry, the aorta's here, and these are their kidneys. And right here, you can see this white thing, and now you can all be radiologists and diagnose that they have a kidney stone. This is the spine right here. It's just that happens to be the slice. But if you look down here, this is another stone in the ureter. So the ureter comes down like this. It comes in and out of the plane. That stone is stuck there, and that's what's causing all the patient's pain, is that stone right there. And then eventually, hopefully, it's going to make its way down to the bladder right here, and then eventually get past. So there's some medications that we use. I had mentioned before, if the urine calcium's high, we often use a thiazide diuretic. Many of you may have heard of this or maybe even be taking it. We most commonly use it to treat high blood pressure, but it's a diuretic. One of its other effects is that it also reduces urine calcium excretion. If the urinuric acid's too high, we may use allopurinol. This drug's often also used to treat people with gout. And if the urine citrate's too low, remember we want the citrate to be higher, we may use something like potassium citrate. And there's been randomized trials showing that these drugs can reduce the likelihood of a kidney stone recurrence by 50% or more. So sometimes people say, well, I don't really want to do a 24-hour urine, it's a hassle. Just give me general advice. And so if I had to give general advice, I'd say, okay, I want you to drink enough to make 2 liters of urine per day. I want to make sure you have adequate dietary calcium intake. And then I want you to decrease your intake of animal protein, sodium, sucrose, and oxalate. But I also tell the patients that I'm just guessing, because you may not need to do all these things. You may already be drinking enough, or maybe you already have adequate calcium intake, or maybe your urine oxalate's low and you don't need to do it. And that's why I really encourage patients to perform the 24-hour urine collection so that we can give them very tailored rather than just general advice. So I'm just going to spend the next few minutes talking about some myths. And these are things that I get asked about all the time. So one thing, and you may hear about this in the lay press, people should drink 10 8-ounce glass of water every day. Well, if you're thirsty, it's fine to drink that, okay? But if you've never had a kidney stone, drinking that much water has not been shown to be beneficial for anything. Many times you'll hear it said, oh, it's good for your skin and this and that. And it turns out if you've had kidney stone, drinking more definitely is effective. But as far as other conditions, it really doesn't seem to play a role, and it'll just make you pee more. So the next myth is people with kidney stone should not eat dairy because they're worried about too much calcium. And I hope that I've shown you that that myth is in fact a myth, when the truth is that the studies have shown that a higher dietary calcium intake is associated with a lower risk of kidney stone. So people who've had a calcium oxalate stone, they do not need to go on a very low calcium diet. So then people with kidneys, another myth is people have been told is that people with kidney stone should not eat green leafy vegetables. Well, it turns out that not all green leafy vegetables are high in oxalate. You may remember from that list I showed you before that spinach is very high, but in fact, kale is very low. And then the last myth that I will talk about is people with kidney stone should not drink alcohol because it is dehydrating. And it is true, if you drink more alcohol, you do end up urinating more. But this idea that it's dehydrating is really a misunderstanding, because if you start to get dehydrated, your body has compensatory mechanisms to make you want to drink more. So if you don't have access to water, then of course that could be dangerous. But for most people that are drinking, they do have access to water. So moderate alcohol intake does not increase the risk of kidney stones, and in fact may reduce it. Okay, so in the interest of time, I'll just summarize here that it's clear that more and more people are getting kidney stones or nephrolithiasis. So we need to think about ways to try to prevent it. And recurrences can be prevented. And we need to reevaluate how we view stone prevention. And I hope I've given you this idea that we really should be thinking about urine concentration. But despite the fact that 19 million adults in the US have kidney stones, I'm embarrassed to say how few randomized trials we have to help guide our approach. So I'll stop there, and I'll be happy to take any questions.
I have a few I'd like to ask Dr. Curhan. The first one is, how long does it really take for a stone to pass through the body?
Yeah, so it depends. And I know you hear that from your nephrologist all the time, but it depends on how big the stone is, depends on the shape of the stone, and it depends where it gets stuck. So some people, it could pass as quickly as an hour, and then there's other people where it could days and days. Actually, I got called just before this meeting. There's a local judge here who has had a kidney stone. It's been weeks since it's passed. So we've been following going down, and we're all hoping it'll pass soon. But as long as you're not completely obstructed or completely blocked, then we usually wait so that we don't have to do a procedure.
Also, are there more symptoms of this condition outside of pain? I know I have a friend that just had one, and he scared me. I thought he was on his deathbed.
Yeah. Actually, my father, who had his first kidney stone before I started working on this, then we talked about it, and wasn't interested in making some changes. And then at the baby naming of our youngest child, I thought he was having a heart attack, but he actually passed out. Had to get an ambulance, got called. He went to the hospital. Yeah, so it's the worst. It's terrible pain.
That's what happened to my friend. He had to go by ambulance. He's always upbeat and everything. And I called him, and he was I heard how he sounded. It really scared me.
Yeah, no, it is scary. Unfortunately, rarely do people die from kidney stones. If there's an infection behind the stone, that can be dangerous, but usually it's just severe pain. For some people, they'll have mild pain, but almost always the symptoms are when the stone's passing. It's not, I showed you that. Okay. The stones in the kidney. Sometimes there'll be blood in the urine because as the stone passes, it can irritate the lining. But those are really the most common ones. But for people that have stones in the kidney, it's rare that there's any symptoms.
Okay. And then I have one more. How do you really deal with the pain? I know that we always hear about the opioid crisis, and it's something that we need to be mindful of. But how do we, manage the pain with that?
Yeah, well, I'm glad that you asked that. So clearly pain control is one of the most important treatments for people in acute crisis. If we can't control the pain, that's one indication for asking the urologist to go in and take the stone out. We're trying to avoid it. And it turns out that non-steroidal, so things like ibuprofen or Advil or Motrin, actually are just as effective as opioids in reducing pain from kidney stones. Now, in the hospital, like when your friend went, they wouldn't give it to you by mouth because oftentimes people have nausea and vomiting and other things. But there is a shot that they can give or give it intravenously, and it doesn't have the same side effects. Now, for people that have kidney disease, we often want to be very careful about them using non-steroidal drugs like Motrin and Advil. But for people that are passing kidney stone, almost always that we use. Again, if someone's having long-term pain, we definitely don't want to get them addicted to opioids. That used to happen quite a bit in the past. But now the urologists are so good at removing stones that there's really no reason that someone, if their pain can't be controlled, that can't be managed by a urologist.
Okay, thank you for that. We do have some other questions in our Q&A section, and I believe in the chat box. So the first one in the Q&A section is by Sasha, and she says, you mentioned geographic differences in the amount of kidney stones. Is that environmental or all factors combined, that is lifestyle, etc.?
Yeah, so I think it's all factors combined. We did a study years ago, and if you just look at the US, there's a west-east gradient and a north-south gradient. But using our cohorts, which come from all 50 states, once we started taking into account diet and some other factors, it didn't seem that the Southeast was higher. So if you don't take into account those factors, it clearly is. So there may be some dietary contributions, and it's not just the heat, because again, the Southeast of the U.S. has higher rates than Arizona, where it can be quite hot. So it's likely a combination of lifestyle and diet.
Okay. The next question is by Shauna. And the question is there a certain nationality that gets kidney stones more often?
Nationality. Yeah, so I'm going to talk in terms of race, which we know isn't a great term either, but just in large categories. So whites are most common to get kidney stones. Blacks actually are much less common to get kidney stones in the US, and that's even taking into account diet and other factors. And that's probably the biggest contrast. And we actually did a study, and it turns out that blacks have much lower urine calcium than whites, and that's probably one of the main differences. I'd mentioned between men and women, men tend to have similar amounts of calcium in the urine as women, but they have much higher oxalate. So Asians are lower than whites as well. And those are really only the three main categories that's been studied. But even Asian, is such a broad term from Northern Asia to Southeast Asia. So there really haven't been enough studies. These are only U.S. studies that have done it by race.
Okay, the next question is, in terms of water, what kind of water should we be drinking? There's like all different kinds, alkaline, filtered.
Yeah. So it probably doesn't matter for the most part. Tap water is usually fine. There are some waters that we call hard waters that tend to have more calcium and magnesium in them, and most of them don't have enough to make a difference. But there are some, and it's usually not tap water because that's more regulated in the amount of calcium and magnesium. And there are some mineral waters that can have very high amounts of calcium in there. And so if people are drinking a lot of water, which of course we want, but at the same time they're drinking lots of calcium. So if your calcium intake is huge, that actually can increase your risk of stones. But as far as for the most part, if you're just drinking whatever water you like, that's fine.
Okay, thank you. Are kidney stones related to kidney cancer? This was asked by, I don't see the name, DLB.
Okay. Not directly, but indirectly. So there's some shared risk factors. So for example, I'd mentioned that obesity is associated with the risk of kidney stones. Obesity is also associated with the risk of kidney cancer. But the kidney cancer isn't related to the kidney stones directly. That's there's the meat of the kidney, but there's also the lining of the kidney. So there is some evidence that perhaps people with kidney stones may have a higher risk of what we call urothelial cancer, the lining of the kidney and the urine. It may be due to the long-term irritation for stones that are there, but it probably, if it is associated, the magnitude of the absolute risk is quite small.
Okay. Next question. You shared that drinks with lots of sugars may have more kidney stones. What about drinks with artificial sugars?
So the artificial sweeteners, we looked at that, and those do not appear to increase the risk of stones.
Okay, you mentioned with the mineral waters already. Let's see. David T says, is there any study to show that immune suppressant drugs can lower or increase the risk of kidney stones?
There hasn't been a direct study. What I'll answer indirectly in that individuals who've had a kidney transplant do not seem to be at higher risk, and maybe at slightly lower risk of kidney stones. So since most of those patients are on immunosuppressants, so it does not appear to be, but there really hasn't been a good study. But if you need your immunosuppressants, don't stop them.
Okay. And then I have, are type 2 diabetics more prone to kidney stones? And does that lead to kidney failure, or does kidney failure lead to kidney stones?
Okay, so I'll break that up into two parts. So the first is, yes, individuals with diabetes are at high risk of kidney stones. And the exact reason isn't completely clear. People with diabetes tend to have lower urine pH, and so that puts them at high risk for uric acid stones. But diabetes also seems to increase the amount of oxalate that comes out in the urine. That would increase the risk of oxalate stones. So the exact mechanism isn't clear, but individuals with diabetes, even after adjusting for weight, and I'd mentioned before that weight's a strong risk factor, still are at higher risk. As far as causing kidney damage, we did a large study in Canada, and it does seem that people with kidney stones are at slightly higher risk of kidney stones, but once you start taking out some of the congenital issues, some of the anatomic abnormalities, the absolute risk is not high. So I don't think that kidney stones themselves are a major cause of kidney failure, whether diabetes or not. I will say that 30 years ago it was a much higher risk, but that's because we didn't have as good instruments to remove stones, and so there was more blockages, more infections, and so they were secondarily causing damage, but the stones themselves weren't directly causing the damage.
Okay, looks like I might have had all of them, but I do have a question, one more. I know there's different methods of removing the stone and based on the size. Is there a standard that is considered the safest? Like my uncle had these as well, and he had to get some boom, or they had to break it up with some.
Yes. So there's a couple different approaches. So the boom was probably the shockwave lithotripsy, and that was a huge advance because that allowed us to break up stones without having to cut people open. The kidneys are very well protected behind the ribs, and so if they had to get up into the kidney, it used to be a huge operation. People would be in the hospital for a week or two, extremely painful. This came out in the mid-'80s where they could put people in a bath of water. That's where the initial ones were, and then they'd use shockwaves and kind of break it up. That, it works pretty well. Depends on the stone and where it is. For smaller stones, it can't really target so well. And it doesn't always, if you have a 10 millimeter stone, you break it up into 3 pieces, and then you pass those 3 pieces, I don't know that that's a success. So more and more, the preferred approach is something called ureteroscopy. And that's where they go in from below into the urethra, into the bladder, and then up the ureter, where they then will either use a laser or a basket and take the stones out. And that, if they can not only go into the ureter, they can go all the way up in the kidney and remove any stones that are in the kidney. So that's become more of a standard. The tools, the instruments have gotten so much better, and that way you can make somebody stone-free, whereas with lithotripsy, the shockwave piece didn't always make people stone-free.
Thank you so much for that information, and I'm so glad I found and learned the scientific term for kidney stones. What a cool word that I can add to my list.
All right. Thank you for inviting me. Enjoy the conference.
Woo!
And a shout out to our corporate mission partners for making this happen.